Good morning. My name is Linda Ercoli, and I'm a geriatric psychologist and a neuropsychologist at the UCLA Semel Institute. And I'm here today to talk to you about managing aggressive behaviors in people with dementia. And just to let you know that you can ask questions on Twitter using hashtag #UCLAMDChat. So tweet in your questions and we'll answer them on air for you. So today I'm going to talk about a number of topics that have to do with aggression, how to manage it, and a little bit about some of the other consequences associated with this very difficult problem that caregivers of patients with dementia contend with quite a bit. So let's talk a little bit about terminology. The first is aggression and agitation. Now, these two terms are used interchangeably, but they're not quite the same. Agitation really is a generic term, and it refers to both non-aggressive verbal and physical behavioral problems, such as when a patient is confused, they may get worked up or pace, but it also does include behavioral problems and verbal problems that are aggressive. Okay, so aggressive behavior means actual hostility, either verbal or physical, that is directed towards the self or other people. So on the verbal end, you have threatening and swearing, yelling. You also have things like sex talk or obscene language, okay? So inappropriate sexual talk is considered aggression. But then you have more physical types of aggression like spitting, hitting, kicking, throwing things, pushing. Could be use of a weapon against another person or the self. And of course, self-harm is a form of aggression. And then there's this area called catastrophic reactions where somebody with dementia may overreact as a result of maybe asking them a question or a minor setback or a criticism. I want to clarify, though, that just because somebody is crying out for help or pacing and wandering, that's not aggression. Now, aggression is pretty common in dementia. The bottom line is about 96%. It occurs at about the prevalence rate of 96% during the course of the dementia. So this means that if you're a caregiver, you're likely to contend with some form of aggression during the course of your taking care of someone. Now, it occurs roughly 20 to 50% of people, but it can be as high as 96%. So the bottom line is, if you're a caregiver, you can expect that you're going to deal with some type of aggressive behavior as the dementia progresses. Now, one study has shown, though, that within about the first year of diagnosis, almost 16% of people who are being cared for with dementia might act violently towards the caregiver, okay? Now, aggression works both ways. So sometimes about 5% or so of the caregivers in that first year were aggressive towards the patient, and then in about 4% of cases within that first year of diagnosis, it was mutually aggressive. So aggression happens both ways, and sometimes when a patient is aggressive, a loved one can return that behavior and react in an aggressive way, and then it becomes mutual. Now, people might want to know, well, does agitation or aggression, when does it happen, and does it matter what kind of dementia my loved one has? And really, the answer is it varies. Think about somebody with Alzheimer's disease. It tends to occur in the more moderate stages, okay, as the severity of the dementia gets worse. But in diseases like frontotemporal dementia, which often present with a personality change or a behavior change early on, that tends then to happen more earlier in that type of dementia. In people with Lewy body dementia, it can happen during sleep. And this is a completely form of aggression that's not intentional in any way. Not that aggression is, but this type of aggression happens during REM sleep, where people with Lewy body dementia often have what we call a REM sleep behavioral disorder, where they act out their dreams. And these dreams are often violent in nature or very vivid, and so the person may be acting to defend themselves in a dream, and this can result in physical behavior like fighting, kicking, and punching. The person who's acting out those dreams has no awareness that this is going on. They have not even a memory for the events. And sometimes forms of aggression, verbal aggression, personality changes can happen before dementia onset is actually identified and diagnosed. So sometimes retrospectively, people notice that their loved one is more irritable, they might be more verbally aggressive or abusive, and once a person is diagnosed, looking back, they'll say, oh, you know what? I noticed this person was different even before they were diagnosed with Alzheimer's disease. Now, the consequences of aggression is one reason why we're having this talk. First of all, it's harmful. Obviously, it can result in danger or harm to the patient or to the caregiver or other people that are interacting or around the patient. But it's also upsetting to the patient. Patients who are aggressive aren't happy, right? And it's a major source of caregiver stress. So it adds to the burden that caregivers already have when they care for someone with dementia. Aggressive behaviors can be difficult to control, and they definitely result in premature nursing home placement, according to studies. And a lot of nursing homes or long-term care facilities either won't accept someone with dementia, or they won't keep somebody there who has dementia. And therefore, this can result in very negative consequences, including restraints, either physical or what you call chemical, meaning that somebody is medicated to calm them down. Now, the causes of aggressive behavior are really multidimensional. The first thing to know is it's the disease, okay? It's not something that's intentional. It's not something that's meant personally, but it is definitely the disease process. And a few reasons why this happens. First has to do with what parts of the brain are affected by dementia. So a number of studies show the frontal lobes of the brain, which are important for managing behavior, like filtering your behavior, inhibiting behavior that's not appropriate, being able to have judgment, being able to foresee consequences of your actions. These parts of the brain are affected in dementia, and so people lose those abilities to kind of hold back and judge their own behavior in a situation. Other parts of the brain, too, though, are affected, like other cortical regions, like the anterior temporal lobes, the parietal lobes, and even areas underneath the cortex, such as the caudate nucleus, can be sites of what we call lesions or abnormalities in the brain. There are also changes in neurotransmitters and in hormones that may affect whether somebody behaves or has a propensity to behave aggressively. And again, we talked about the cognitive deterioration, especially these functions that are controlled by the frontal lobes, like judgment. Now, there are other causes. When you think about that, the dementia itself sets up a vulnerability for these kinds of aggressive behaviors. Now we have on top of it a few categories of things for you to think about that add to this and might trigger or essentially release or set the stage for these disinhibited behaviors to occur. So one includes difficulties with communication. So when someone has dementia, they have really language problems. This includes difficulties understanding behavior, difficulties communicating their feelings and their thoughts, and they're not necessarily able to formulate a concept about what's going on around them. So somebody with dementia can't tell you, I'm upset. I don't understand what you're trying to say to me. So they may act out behaviorally with their frustrations and their confusion. So usually if there's some kind of agitation going on, it's helpful to think about it as somebody is having a communication problem. They're trying to tell you something and you have to be a detective and figure out what it is. Then there are internal factors. That means what's going on inside the patient. And this could be anything from psychological factors like they're feeling fear or anxiety, or it could be biological factors like they have an infection. So you often see urinary tract infections causing a delirium, which in return is confusion and agitation, and people can lash out aggressively. Sometimes medicines and definitely alcohol can unleash these kinds of behaviors. And finally, there's the environment. So what's going on around the patient? And it can be anything from who's in the room, what your behaviors are as the caregiver, what's going on the television set, what's the temperature like, all these things that perhaps are bothering the patient and they cannot communicate you with what's going on, they don't understand what's going on, and they may act out and lash out. So let's look a little bit more closely at these types of problems. So this is a good way to think about it. It's usually somewhere among these three or all three in combination with each other. So usually what we call something that sparks or releases or causes a behavior to manifest is called a trigger. And you can see from this chart that there is a lot of different things that can trigger a behavior. So we talked about those three major categories, but let's split a few hairs here and look more closely. So if you have somebody who's acting out, you might want to you should be thinking about any of these possibilities. So one is somebody, again, has psychological factors: depression, fear, anxiety. They're not able to communicate. They're frustrated, so they can't do a task that they used to do or a task that you're asking them to do. It's too complicated or they don't understand it. They could be in a new surrounding, a place where they've not been before, or the place where they are doesn't seem familiar to them anymore. Could be loud noises in the environment, like chaos, people coming and going. Violent shows on TV, because people with dementia have a difficult time separating what's real from what's not real. And physical discomfort, so pain, hunger, thirst. And again, we talked about biological factors like delirium and other illnesses, infection. So again, if somebody has depression or mania, if they have anger, if they're frustrated, these can be considered triggers, more along the psychological spectrum of aggressive behavior. Paranoia and suspiciousness, so delusions, can trigger aggressive behavior. So here are some examples, and if you're a caregiver, you may have heard these before, like, my daughter is trying to poison me, my daughter is trying to put me away, my husband is cheating on me. And particularly these delusions about a cheating spouse can engender aggression in a patient, sometimes towards the spouse and sometimes towards the person they think is cheating on them with the spouse. Also, prior personality and behavior. So if you have a person who has, or a loved one who has a tendency to have been aggressive or very reactive in the past, this can be a behavior that is more easily manifested once dementia sets in. Again, if you think about it, it's these frontal lobe functions that a person doesn't disinhibit anymore. So think about when you're driving on the road and you get road rage, you might be very angry at someone, but you're not necessarily going to run them down with your car, at least we hope not. Somebody with dementia wouldn't be able to really inhibit that behavior. So what they're thinking, they may act out, even though normally before dementia they would not do such a thing, or maybe they had a tendency to do it, but now it just comes out much more easily. So what you do in these situations is you try to treat the underlying psychiatric problem. If somebody has depression or mania, you would want to treat it. And again, if you are interacting with someone, maybe you are giving them too complicated of instructions, you're asking them to do things that they can no longer do, you want to change your communication style and rethink how you're interacting and what you're asking that person to do. Environmental factors include, again, what's going on around the patient. So anything, things that you may not think about, and you simply go and turn down the thermostat. A patient who can't do that might get testy or edgy if it's too hot or too cold. Important is the attitude of the caregiver. So even though patients may not be able to communicate well, they can pick up on emotions. So if you're angry, you're stressed, if you're impatient, if you're rushing someone, this can help trigger aggressive types of responses and reactions in someone. Now, in long-term care facilities, nursing homes, roommates can trigger aggression in somebody because let's say somebody is yelling and screaming in the bed next door, or somebody wanders into another person's room by accident. This can trigger an aggressive response. Taking somebody on vacation sounds like fun, but this can cause confusion in a loved one, and sometimes it results in someone acting out and lashing out. And finally, changes in personnel, like having a lot of turnover of caregivers, can result in these types of lashing out behaviors. They don't know who they are. Remember, it takes a long time to learn and get to know someone, and they cannot even sometimes recognize them from time to time. So changes in caregivers can be a source of lashing out and aggression. So in these cases, if it's you and your attitude, you try to change your behavior and try to adjust the environment. Now, what about the medical or biological triggers? So we talked about delirium. Pain is another factor. It definitely can result in people being cranky, irritable, and acting aggressively. Believe it or not, constipation has come up in a number of studies as a source of potential acting out of aggressive behaviors because it's painful, because people are uncomfortable, and remember, they can't tell you, and they may not understand that this is what's going on with them. So some medications and medication interactions, for example, drugs like benzodiazepines, so drugs like Ativan and Valium and drugs in that family of medications can disinhibit patients. Some medications that increase dopamine can cause aggression in patients that take those medications, like patients with Parkinson's disease. Definitely alcohol intoxication. So if somebody is intoxicated and they have dementia, they definitely can act aggressively. And it also, even if they're not, floridly drunk, alcohol can cause disinhibition. And finally, we talked about those REM sleep behavior disorders. So what you do in these cases is you treat the underlying medical condition, and you definitely would, if your loved one is showing these changes, talk to your doctor. Perhaps they need a medication reconciliation, they need a review, and definitely eliminate alcohol from their diet, their recreation, and their relaxation. Now, what about the caregiver as a trigger of aggression? Well, sometimes it's what you do, and sometimes it has nothing to do with what you do. One of the things that happens in dementia is that patients tend to not recognize who they're relating to. They may not recognize a caregiver. They may not even recognize their own adult child. So that person can be perceived as a stranger, and so they may act defensively. They might perceive just being cared for as a threat, so giving medications, especially if someone is delusional or they think they're being controlled, that might be a way that the caregiver would trigger aggression. Definitely, we talked about the caregiver's attitude before, but let's revisit that. Confrontational, punishing, impatient, and critical attitudes from the caregiver to the patient is not a winner. It's going to create this type of aggressive response. So definitely, you have to think about, okay, I'm angry, I'm not happy, but when you're with the patient, try to remember that you're dealing with someone who can't control their behavior. It's not personal. And whatever you do, don't confront and escalate a situation. And sometimes a caregiver can just react. And that reactiveness to an inappropriate behavior sometimes is what keeps the behavior going. So this happens in patients who are sometimes sexually inappropriate. So they may expose themselves to someone, and actually the shocked reaction on someone's face can actually reinforce that behavior. There are a common reason for this aggression and animosity between the caregiver and the patient can be just unresolved biases or issues between the caregiver and the patient from the past. So perhaps you've had a contentious relationship with the person that you're taking care of, and sometimes this plays out even in the caregiver care recipient relationship. The sex of the caregiver is an issue, especially in the cases of inappropriate sexual behavior. Sometimes you're better off with a same-sex caregiver, especially if you have a male patient who is acting inappropriately towards a female caregiver. It could also be sometimes people feel during bathing, they become very private. They feel like any of us would. Modesty is an issue, and so having a caregiver of the same sex sometimes doesn't work, especially for men, but sometimes having a caregiver of the opposite sex, again, doesn't work for both men and women. So that's a trial and error situation. And sometimes it's just a specific person, has nothing to do with the behavior of that person, but that individual may remind them of someone that they've had a contentious relationship with before. So in this case, again, adjust your behavior or your attitude, and you might have to consider a change in personnel. So let's go over some specific do's and don'ts. So now you have your general framework for thinking about what can trigger aggressive behavior. So we talked about communication, we talked about internal factors and external or environmental factors. Now let's go into some specific do's and don'ts. So think about what keeps an aggressive behavior going. That's called a reinforcer. And this can happen, it can be completely inadvertent on your part or even unexpected. But a patient gets a desired outcome, and that outcome keeps that behavior going. It's like a reward. So avoiding something that somebody doesn't want to do, like taking a medication or getting a bath, coming out of one's room, by chasing someone away or acting aggressively, they don't get the medication, then the patient learns that that's a behavior that will bring about that desired outcome. Again, people can want attention. So let's say you're ignoring somebody, or a caregiver, again, unintentionally is ignoring someone, all right? This isn't about blame or doing wrong, but things happen. You're busy doing something else, the person feels ignored, and they may yell or say something or act inappropriately. It gets your attention. So that's a desired outcome. And we talked about caregivers' reactions. Usually being calm is definitely a good response or reaction, even leaving the room if you need to, but not looking too perturbed, not escalating a situation by confrontation. So again, the object here is try to figure out what's keeping that behavior going and try to eliminate it. Let's talk about communication. So do communicate. People who can't express themselves verbally or understand what's going on might lash out. So let's take this scenario. Jorge refuses to follow instructions. So you might think, oh, well, he's just being difficult. And he might yell, he might have a tantrum, he might throw something. First of all, can the patient understand speech? So is his level of dementia so severe that he cannot understand what you're saying, or you're talking too fast and he can't catch it? Does he speak a different language? Does he have vision or hearing problems? So definitely hearing problems, people miss a lot of information and it causes frustration. This is true even in someone who doesn't have dementia. It's even worse in someone who has dementia and a memory problem. So you want to enhance communication. So always identify who you are and why you are there. Don't assume that that person knows that. Don't assume that somebody remembers you. Be calm and soothing when you approach someone, and try to be at their eye level. Okay, make eye contact with people and listen and be reassuring. And that can include some reassuring touch. All right, a gentle touch on the shoulder, provided again that if that person does not accept that, then you wouldn't want to try that again. Pay attention to what your body language and your facial expressions are saying, and ask about specific wants or needs. So do not say, what do you want lunch today? What do you want for lunch today? But do you want a sandwich? Do you want a chicken sandwich or a ham sandwich? So would you like a glass of water? So this avoids the frustration of somebody having to make a decision and feel overwhelmed by that. And then again, keep communication in general just short and simple. One-step commands, and tell people what you're going to do next. Here's a don't be insensitive. Again, this may not be what you are trying to do, but it will come off that way to the patient. So here's a scenario. Your mother yells at you, I did not, when you say to her, I already told you where we are going today 10 minutes ago. Sound familiar? So what could be going on there? Well, be mindful of people's dignity. If people are feeling criticized, that could bring out a lashing out type of behavior. Don't remind somebody that they have a memory problem, and don't test their memory. By virtue of somebody having a memory problem, they can't remember that they already asked you a question. So even though you know they've already asked you 5 times in 10 minutes, every time to them is the first time. Don't say I already told you that. And a good rule of thumb is try to use honey instead of vinegar. So if your mother asks you, gee, where are we going today at 10 o'clock? It's a good idea to have a big calendar in your main room, or even a calendar that you give someone every day, and you can refer them to the calendar and see, look at the calendar, there's your schedule for today. And that's a good way for you too, to feel like, okay, I can cope with this, I can deal with this frustration. I'll just refer them to their calendar. The wrong approach can lead to catastrophic reactions. So here's another example. So Bill is seated at a table, and the caregiver approaches that patient from behind and puts a puzzle in front of him. And he screams like, get out of my house, and he throws the puzzle across the room. Again, the caregiver intentionally do something wrong? Not at all. But it's how the patient is approached that is important here. So try to approach somebody from the front, give a greeting, make eye contact, and tell the patient what you're going to do and what you have. So saying, hi, Bill, from the front, and giving him a puzzle and say, let's play with a puzzle, or let's do a puzzle together, would tend to avoid that type of a catastrophic reaction. And we've talked already about don't confront. But essentially, somebody with dementia, they can't reflect on their unacceptable behavior. And it's not something that they're doing on purpose, and it's very difficult to control for them if they can control it at all. So try not to confront somebody, and whatever you do, don't initiate physical contact during an outburst, because that's going to escalate it. And think about safety first. So first and foremost, remove guns and other weapons from the home. And that includes making sure that you don't have bullets, etc., in the home. Always leave a situation if necessary. Do not get into a contest with someone. Lock up sharp objects. And lock up medications too, because people can take medications to harm themselves. And they can take sharp objects and use them against themselves or you or another person. Here's a great do. Distraction is your friend. It's a great tool to use for most kinds of behavior problems, and that includes aggressive behavior. So give somebody something to do. Boredom is not a good thing. So exercise and expend energy, because people can get pent-up energy and then they can become agitated and they can become aggressive. So adult daycare is a good option for people, where they go for several hours during the day to a center. They play, they have activities, they have lunch, and when they come home, they're tired. It's a good thing, okay? And give someone a daily schedule, something for them to look forward to. Because when an individual has a memory problem, it's like putting a paper sack over someone's head and dropping them in an unfamiliar space. They don't know where they are, they don't know what's happening, they don't know what's coming up. And so having a structured type of schedule that people eventually can learn and look forward to, like lunch at a certain time, a walk at a certain time of the day, bed usually at a certain time, is very helpful in avoiding these kinds of agitating, aggressive types of behaviors. And distraction involves things like just simply change the subject. Put on pleasant, soft music. Offer a snack. Talk about the past and things that people know. So this might mean getting out a photo album. And go for a walk is a great way to distract someone. So chill out. That's something to think about. Here's the case. Mrs. Smith yells at you when you come to give her medication. She does more than yell. She throws it in your face. What can you do in those situations? Give her a timeout. Give her a chance for you to chill out and for her to chill out. And come back in a few minutes and try again, but have a different approach. Another way is, again, you can try to ignore behavior. So if somebody swears at you, try to ignore it and see what happens. Immediately looking shocked could reinforce that swearing. So see if ignoring it works. And try to address what someone is feeling and reassure them. So it's very natural for people to focus on the behavior, but really the communication with somebody who has dementia is on a feeling level. So try to reassure them. Say, I can see that you're scared. Don't worry, I'm here to help you. And again, don't take it personally. And this is a hard situation that a lot of people run into. Their mother screams at them and says, you're the worst daughter in the world. It does hurt, but those behaviors are not personal. Try to keep your cool. Don't punish the patient. And in these situations, maybe a good way to cope would be, to really think about the emotional burden of dealing with this. Give yourself some slack and say, you know what, I know I can't, this behavior, I can't get rid of it, but I have to tell yourself, this is part of the disease. This isn't a vendetta against you. And again, we're only human, and we tend to go there sometimes, but that's not what's going on here. And then you can devise specific plans to really focus in on, okay, how do I know really what the triggers are? because that can be tough to figure it out. You know in general the universe of triggers, but which one is operating in this situation? So you can develop a behavioral modification kind of strategy based on trying to identify these triggers, like what's happening right before the behavior, what's the situation in which it's occurring, who are the players, who's there, when does it happen, because that matters sometimes, time of day, and what happens right after that behavior. The idea here, though, is not to expect that you're going to completely eliminate a behavior. If it were only that easy, but it's not. But the goal here would be to try to reduce a behavior or avoid the circumstances in which it occurs. So once you can figure out these triggers, then you can develop the plan to intervene. And you can simply make up a nice behavior log like this for yourself, where here's the behavior. So in this case, you would say, Dad threw his glass of water at me. Well, what happened right before that? All right, who's involved? When does it happen? And you fill in the blanks. And over a few days or a week, a pattern should occur or emerge. And it's from doing this every time that behavior happens that you can learn what the triggers are. And you can learn what might be a possible way to reduce that behavior or manage it. So let's try this one. Your loved one says, get the hell out of here when you intend to give a medication, and they throw the glass of water at you. So what could be happening? Well, what happened right before? You walked into the room and said, time for your medication. It's like, why should that make anybody angry, right? But this is true. Well, what happened right after that person yelled at you? Well, you got offended, you looked maybe angry, and you yelled back, come on, Dad. You do this to me every time. And again, that might work in somebody who's not demented, but this is a different situation, and this can escalate the situation. So try to develop a plan. You might want to approach somebody a little more calmly and quietly, and maybe have a letter, even a letter that's a phony letter from the doctor, saying, hey, Dr. Williams, your cardiologist, wants you to take this medication to keep your heart healthy. So sometimes a little white lie like that can really help in getting somebody to go along with you. If that person, though, becomes aggressive, go away and try again, right? You might need to revise the plan. You might need to just give medications in applesauce. It could be just swallowing the pill is what's hard for the person, and having it in applesauce might help. So you have to be a little bit, again, of a detective to figure this out. Now I'm going to talk about two situations where aggression is really common, and one is during personal care. So especially centering around private matters like bathing and toileting. Always think about this is about dignity and modesty. It can be about seeing less of a need for bathing, uncomfortable with help and perceiving it as a threat, a bathroom being a scary place full of echoes, and let's face it, it's not the most warm and fuzzy room in the house, and somebody being afraid of slipping or falling. So one of the things you can do is watch your language. And I'm not talking about bad words. I'm talking about the word take a bath. That alone can set some people off. So you might want to use a word like let's get clean. Try to think about a reward like, hey, after your spa treatment, let's go get a snack. Let's take a walk. Make the bathroom a nicer place with scents and candles, flameless candles. But very importantly is modesty. So cover the person up with the towel. They may not want to be seen completely unclothed in front of you. I mean, if you put yourself in their place, think about that, right? And have them help as much as possible, because people like to be as autonomous as possible. Have them redirect the shower head. Have them scrub. If they can do it, let them do it. But definitely allow more time. So you might take 10 or 15 minutes to take a shower. It's probably going to take 40 minutes with your loved one. And make sure there's proper safety equipment. And if the morning doesn't work, try a shower in the afternoon. And remember that you don't have to give someone a shower every day. 2 or 3 times a week with sponge baths in between is sufficient. Inappropriate sexual behavior is another problem that people encounter that can be considered aggressive. And it definitely can happen depending on the prevalence. It's not well studied, but up to 30%, depending on the study. And it's definitely higher in institutionalized settings. It's more common in men than in women. And it's definitely a higher rate of occurrence in younger men who are more medically healthy. And these behaviors can be masturbation in public. It can be sex talk or obscene language, unwanted advances, and of course, inappropriate touching. And it can be implied acts, and that really is just reading something like pornography in public, asking for unnecessary genital care. So those can be forms of inappropriate sexual behavior. It makes people very uncomfortable. And if you're a caregiver and you feel uncomfortable about this, so will a paid caregiver. Especially, too, everybody interprets this differently, especially if you yourself have a history of sexual abuse or trauma. It's going to be hard for you to deal with. It's hard for anybody to deal with. Again, this is a part of the disease. It's part of the brain dysfunction. It also can be related to loss, like if people have lost a sexual partner. They could be understimulated. In other words, remember boredom? Not a good thing. And they might misinterpret cues. So if a caregiver is bending down in front of someone, they might think, oh, this is an invitation, but it's not. But they misinterpret that. And, you know, they may have had a history of inappropriate sex or high sexual activity when they're younger, and their behavior, now they're more disinhibited. And definitely make sure that this is not about alcohol and have the medications checked. It's not an easy behavior to manage, but think about keeping people busy. So redirection, again, is your friend. Increasing socialization, using same-sex caregivers. And remember, if somebody is depressed, you want to treat these underlying illnesses. It's very difficult to say, I think so-and-so should have a sex partner, because this raises ethical issues, because both partners, you know, have to have the capacity to consent to sex, right? And STDs, or sexually transmitted diseases, is not just an issue for the young, it's also an issue for the old. So safety becomes an issue. I briefly want to touch on suicide and homicide because it happens, and this is not an easy thing for people to think about or talk about, but we really need to go there. So let's first talk about suicidal thoughts, risks, and attempts in the patient. It's not well studied. There aren't a lot of controlled studies or very good, rigorously, scientifically studied studies out there on this. But the prevalence of suicide attempts, depending on the study you read, can go from 5 to about 12%. Certainly people with suicidal ideation suicidal ideation can be expected in people with a new diagnosis who are in the early stage of dementia. Nevertheless, it should be taken seriously. And if somebody is having these thoughts, they should be encouraged to talk about it and really talk to the person's doctor. Definitely, if somebody has a plan and a time where they want to do it, this means it's even more serious. So those are to be taken seriously. Suicidal ideation might become more linked to changes in judgment and frontal lobe dysfunction as dementia progresses. And it seems, according to one study, that people at highest risk for it would be men, highly educated and professional, who have depressive symptoms that come on after they've been given a diagnosis. But they may be insightful nevertheless, and they have suicidal thoughts. But again, it's not limited to this population, but this is a profile of someone who tends to be at high risk. And one thing that people who have suicidal attempts have in common is that they may be delusional. So especially delusions associated with a spouse cheating. And people will try to take their life in many different ways, but self-poisoning, overdosing, etc. is common, as followed by hanging and drowning. Homicide is when someone, of course, takes the life of another person. Very few studies on this. Homicide by patients is uncommon, but generally the risk factors for violence in patients include frontal lobe lesions, a pre-existing history of aggression, catastrophic reactions, and alcohol abuse. Caregivers, on the other hand, they also can be worried about if they're going to become violent. And about 20% of caregivers do live in fear that they'll become violent, according to the National Center for Elder Abuse. Now, will they become homicidal? Well, it does. Again, it happens. Murder-suicides are rare, but in those cases, usually the caregiver is the perpetrator. And these are caregivers who are depressed, they're isolated, they may be feeling like they want to end the suffering for the patient and for themselves. Family carers, may be at high risk for suicide themselves. And there was a survey of about 566 family caregivers, and about 16 to 26% contemplated suicide in the previous year. About 30% said they would try it in the future, and about 50% only actually talked about it with somebody else. And again, you have depression, poor coping ability, less confidence that you can reach out and get help. These are risk factors for this. So what you do is, definitely get help. You can contact the Alzheimer's Association has a hotline. You can contact Adult Protective Services if you fear for yourself or you fear of hurting someone else. Definitely go to a support group, although I would not suggest you go there in an emergency if you're suicidal. If it's an emergency, you go to an ER room, you call a hotline, think about getting psychotherapy for yourself, and if your patient loved one is aggressive, talk to their doctor. If there is a child in the house, this is a potential. If violence has been acted out towards the child, then this becomes a Child Protective Services issue. If violence has been put against you and you're over 65, then you are the victim and it's an Adult Protective Services issue. I'm not going to say much about medications except that they are the last resort for aggression and sexually inappropriate behavior. It doesn't always work, and it might make things worse in some cases. But if somebody is not eating due to severe depression, they're injurious, it could be an emergency. Consider, though, the risks versus benefits. You want to use the lowest dose that works, and you start out really low on your dose and you go up very slowly. There are side effects, and the idea is if somebody goes on one of these meds, it's to wean them off after a while. And just about many drug classes are used to treat aggression. So anxiolytics can be for agitation and resistance. Often antipsychotics are used for when people are delusional, antidepressants for compulsive behaviors and for underlying depression. But again, these are not the first resort, and it comes with a lot of ethical considerations to use drugs. So talk to your doctor. And again, this is where you can get help. When do you get help? Time where they want to do it. This means it's even more serious. So those are to be taken seriously. Suicidal ideation might become more linked to changes in judgment and frontal lobe dysfunction as dementia progresses. And it seems, according to one, help. And so these are the various resources on the right for talking to get help. again, suicide hotlines, your doctor, and at some point, please go to a caregiver support group, because there you will learn the skills for dealing with these kinds of behaviors and will reduce depression. These are great resources in general if you have a loved one that you're caring for with dementia. The Alzheimer's Association, even if your patient or your loved one doesn't have Alzheimer's, caregiver support groups. We have videos here at UCLA that we developed, and you don't have to be a patient or a patient at UCLA to watch them. They're available online at dementia.uclahealth.org. So this webinar will be up there on demand. We have other webinars that have to do with caring for patients there. And there are great resources like the 36-Hour Day is sort of the go-to book for dealing with people with dementia and for caregiver stress. And another is Learning to Speak Alzheimer's. But really, if you go on the internet, you go to Amazon or some other source, you can find a lot of different books there. This is a sample of what our behavioral management videos look like. And again, you'll see about 6 or 7 of them on the internet to help you deal with specific problems. And the UCLA Alzheimer's and Dementia Care Program, again, visit us online. You don't have to be a patient. There's lots of great information there for everyone. So you can ask questions on Twitter now, and I'll take questions. Let me take that. Thanks. All righty. How is aggressive behavior extrapolated over a culturally diverse population? Well, that's an excellent question. First of all, I want to say there aren't a lot of studies on it because there aren't a lot of studies on aggression. But I think you have to think about how is aggression expressed in a culture, and that's one way to think about it. The other is, what about the individual? So you're always looking at the individual. What were the individual's tendencies before they had dementia? What are the health issues that they're dealing with? So some of those basic factors stay the same, but what would change would be the individual's experience, their prior behavior, and of course communication. Because I think this is important when you're dealing with people communicating from different cultures. This adds another parameter of complexity to the situation. Is, are they understanding each other, and are they speaking the same language both linguistically and culturally? Other things to be thinking about is, what is the relationship between men and women in the culture? What is the perception of being touched in the culture? How do people feel about close proximity in the culture, right? So these are things to think about. Some cultures are very close when they speak to each other. Other cultures stand farther apart. Cultures have different feelings about being cared for by the same sex versus the opposite sex, the role and appropriateness of the opposite sex in contact or in the room with someone. So I think all of these things would be culture-specific considerations. Next question, is it common for dementia patients with English as a second language to digress back to their first language? Yes, it is, but remember that language in general deteriorates in dementia. So usually the more recently acquired language deteriorates first, but people can also deteriorate in their native language. Our mind-body approach is useful for people suffering from dementia. We've had more research on this lately. It's not well researched, but the answer is they can be helpful. Deep breathing, relaxation techniques, even some evidence that aromatherapy can be helpful in the person with dementia. Now, it doesn't mean that they understand that they are using a mind-body approach, right? But you helping them engage in one could be helpful. Whether they can actually meditate, that's really debatable. but they can take advantage of relaxing environments, sometimes sensory stimulation rooms, things like that can be very helpful. Okay, so those are the end of the questions, and I want to thank everybody for tuning in. Thank you very much.